Hello, everybody. Welcome to today's Raising the Bar for Maternal Health, Equity and Excellent discussion about how healthcare provider institutions can work through and beyond clinical care delivery to improve maternal and birth outcomes. My name is Sinsi Hernández-Cancio. I use pronouns she, her, and ella, and I am the Vice President for Health Justice at the National Partnership for Women and Families. We're a nonprofit organization that has been around for a little over 50 years, working to improve the lives of women and their families through health and economic justice. Our organization, the National Partnership, with the support from Robert Wood Johnson Foundation, developed a use case for Raising the Bar's actionable framework to help embed maternal health equity throughout healthcare organizations. We know that providing direct care is critical to advancing maternal health equity, but we also understand that healthcare organizations must look beyond just their role as care deliverers to truly embed equity in everything they do and to really be able to move the needle. Our panel today will discuss how their organizations are promoting maternal health equity as community partners, as employers, and as advocates. Before I introduce our panelists, I'd like to welcome Andrea Dukas from the Robert Wood Johnson Foundation, who was a program officer for this groundbreaking work. Andrea?
Thank you so much for that introduction, Sinsi, and to everyone for joining us today. As Sinsi mentioned, I'm Andrea Dukas from the Robert Wood Johnson Foundation, which is the nation's largest health and healthcare foundation. And we've had the great pleasure of supporting Raising the Bar since its inception. And for me, it's been a true and personal honor to be part of the program since its early days, back when we were ideating. This was an idea on a whiteboard. And to be here with you all the way through now at an event like today's with so many people here who want to learn, grow, and make real progress. I'm thrilled at looking at the participants in the chat and seeing just where you're all from. And I mean, what a great group. So thank you again for being here today. So at RWJ, we invest in this work and many of our other programs because we believe that all families should be able to access the resources they need to be healthy and to thrive. And of course, that includes having access to high quality and affordable health care. We are strong proponents in the Raising the Bar framework and believe that it plays an important role in making this vision a reality. Which is why we partnered with the National Partnership for Women and Families to support them in releasing the use case that Sinsi mentioned, the Raising the Bar for Maternal Health Equity and Excellence report and suite of materials, which is applying the Raising the Bar framework to advancing maternal health equity. So you may know that the Raising the Bar for Maternal Equity and Excellence was developed with guidance from those who get care, give care, and pay for maternal health care, including so many experts in reproductive and birth justice, perinatal mental health, nursing, social services, quality improvement, community engagement, and more. So we hope that these tools really appear to be grounded in a plurality of perspectives, and especially those perspectives with the most at stake in this issue. So I really hope you'll take time after today's event to look through the full report, which not only includes fantastic recommendations, but also concrete actions you can take in applying this framework according to who you are, where you sit within an organization, the kind of organization you're at. There's a lot of specific guidance in there, which is wonderful, including recommendations for C-suite executives, boards of directors, administrative leads. And you'll also find in the materials stories of institutions that are implementing the framework, some bright spots, and operational guidance on maternity care quality measures and also payment reform. And we hope that you'll use these tools to help not only improve the quality of maternal care that you all either provide or facilitate, but to help us change the trajectory of the country's current and horrible maternal health crisis. So I can't wait to hear from our panelists on these topics. I will take up no more space and turn it back to you, Sinsi, and just thank you so much again for this great event and for inviting me to join you.
Thank you so much, Andrea. So before we dive in, I do want to spend a few minutes talking about why this is so important, especially for me, because I think it really grounds us in the realities of what we're trying to fight against. Exactly 17 years ago to the day, I was in the hospital. I had just given birth. I would end up spending a total of 16 days in the hospital as a result of a cascade of mistreatment, errors, being ignored, not being listened to. First, I was sent home against the instructions of my maternal fetal medicine specialist with preeclampsia. The next day, with her urging, she said, you have to go back. You have to be in a hospital right now. There was a failed induction. There was an emergency C-section, and thank God that my son was completely healthy and okay. But I quickly developed an infection. I was sent home 4 days later, on Mother's Day, no less, with an infected wound. Within 3 hours at home, I spiked a fever to the extent that I was practically delirious. I was experiencing what seemed like a scene from a horror movie where my cesarean incision burst open with a shower of blood and pus. I was getting septic. So I was back in the hospital with a newborn in the ER and ended up having to be readmitted, having 2 surgeries after the initial C-section. And as I said earlier, being in the hospital a total of 16 days. As a result of all of this, I don't remember the first several weeks of my son's life. It was excruciating. It was terrifying for not just me, but for my husband and for our family. It was a truly traumatic experience. And at no point was there any help offered to deal with, first, the enormity of nearly dying, but also just the overall trauma that we had all experienced. In fact, what happened was the opposite. When I went, after I was out of the hospital, and I went back to see my OB in the follow-up appointment, and I asked him, what happened? His answer was a joke, literally a joke. Oh, it must have been all that dirt that I sprinkled into your wound. And that was my experience in bringing my amazing, wonderful son to the world. This is not, unfortunately, this is not rare. And it's not just a question of people not knowing the rights or knowing what to ask for or having the right insurance or any of these issues. Because here I was, an Ivy League educated doctor who works in health policy, who had Cadillac insurance, thanks unions. I worked at a union at the time, and had been able to assemble a whole team of specialists to deal with some of my, previous chronic known issues. I knew what to ask for. I knew what I needed, and it didn't matter. It didn't matter one bit. I was still ignored. I was still sent home extremely sick. I still almost died despite all the efforts that I made to have anybody listen to me and give me what I knew we needed to be healthy. So it is with incredible humility and purpose that I felt like the universe conspired to help me be in an organization where I could lead work in trying to make this different. And so when I got the opportunity to work with a national partnership to come over roughly over 3 years ago, and saw that this was part of the first major project that I'd be working on, I felt like the universe was giving me a signal about where I belonged. So I can't even begin to describe what an amazing experience it has been to be able to work not only on this issue, but also with the incredible team at the foundation, all of the different organizations that we've worked with and partners. And so that's why, we're here today. As you know, we face this ongoing and growing maternal health crisis, and it's driven by widening disparities. And a lot of people, for example, don't realize that me as a Puerto Riqueña, as a Boricua, we actually have much worse outcomes than the general Latino population, and people don't necessarily know that. But as healthcare providers, you have a responsibility to create and maintain a maternal healthcare system that really prioritizes equity and ensuring that every birthing person has access to high quality person-centered care. And the key to that is listening, right? Is empowering the patient and their family to be a partner and even a driver in the care that they need. Now, as much as we need to improve quality, we need to embed equity in everything that we do. Quality measures, demographic data collection, payment programs are all important things that healthcare organizations need to do to embed equity into maternal health. But we also have found that it's really important, and you can read this in our Maternal Health Equity and Excellence report, that there are 4 key roles that hospitals and healthcare systems, independent women's health providers, et cetera, all need to play to together make the difference that we need. And yes, it's as providers, and there's a lot that we need to be doing better as providers, but also think about your role as employers, your role as community partners, and that's going to be a huge key, and your role as advocates, because you all have a powerful voice, sometimes more powerful than you imagine. And what we want to do today is dive into some examples of different institutions that are taking these roles to heart. So our panelists today represent the different roles that these healthcare providers can play. We will be speaking to actions and strategies and solutions that leaders can implement to commit their organizations to maternal health equity. So let's start. I want to introduce you to our esteemed panelists, Dr. Abika James, Patty Graham, and Joshua Traylor. As we get to know our speakers, I'd like to pose a question to each of you, just to get us started off. So remember the question. From your perspective and experience, what can healthcare provider institutions do to improve maternal health outcomes? Dr. Abika James is Vice Chair for Diversity, Equity, and Inclusion and Associate Professor of Clinical Obstetrics and Gynecology in the Department of Obstetrics and Gynecology at Penn Medicine. She co-founded the Penn Department of Obstetrics and Gynecology Health Equity Task Force, leads the department's core missions of clinical care, leads the department health equity and anti-bias initiatives, and works to ensure that DEI is infused into the department's core mission of clinical care, education, and research. Abika, what has Penn done that healthcare systems can learn from to improve maternal health outcomes? And I know that what Penn Medicine has done is multifaceted. It's an enormously interesting and successful project. So I'm gonna have to ask you to pick just like the one thing that you want to communicate.
That's correct, yes. Thank you, and really a pleasure to be here. So what I would sort of start with, and hopefully sort of through the discussion, we'll speak a little bit more, acknowledging definitely everything that you said, Sinsi. But what our institution did in 2021 was set from the top. So our CEO set as an institutional team goal the reduction of maternal morbidity and mortality in Black women. And so when I say as a team goal, this was across all 5 entities. And this really set the stage for an entity-wide commitment to this reduction, facilitated collaboration, education, and several other efforts that we could go into, and allowed me in my role to focus on this and to unify the entire department around this goal and really start to increase efforts. And we were successful in reducing within our sphere by 29% in 1 year.
29% in 1 year. That is amazing. And we're going to be hearing a little bit more about your work shortly. So now let's move up a little bit north. Patty Graham, what would be the answer for you of the most important thing from your experience that systems can do to improve maternal health outcomes?
Good afternoon, everyone. Thanks, Sinsi. I would say that the most important thing you can do is listen to your community. Health Partners has been looking at quality improvement through an equity lens for several years. And when we started thinking about how to improve birth outcomes for families of color, we went to the community to hear what people in the community and birth workers on the front lines had to say. And we heard loud and clear they wanted support from people who looked like them, and doulas were an obvious strategy. In Minnesota, doulas have been a benefit for Medicaid members since 2014, but there's a lot of barriers. And so our work was really to kind of take on those barriers and make it easier for that work to happen and for the partners to get paid for the valuable work that they're doing. We focused on creating opportunities for BIPOC people to become doulas and get paid for it. And it's ongoing, but there's already been quite a lot of work that has happened in Minnesota, thanks to our partnerships with doulas and with other allies in this work.
Thank you so much. And now turning to Joshua Traylor, who's the Senior Director for the Healthcare Transformation Task Force, where he leads efforts to improve the design, implementation, and operation of public and private sector alternative payment models. I should say that the Healthcare Transformation Task Force is also a core partner in our Raising the Bar work with the partnership. He has supported state efforts to reform care delivery, led the development of the Center for Medicare and Medicaid Innovation child-centered care model, among many other things. Josh, you have a slightly different vantage point. What would you say is the most important thing that healthcare institutions should be doing to improve maternal health?
Oh, Sinsi, thank you for the introduction. And yeah, the task force really works to bring together payers, providers, patient organizations, and purchasers who are all focused on advancing healthcare delivery by changing the way that we pay for care. We've had the good fortune to be involved in both the Raising the Bar Round 1 and Round 2 initiatives, and I and my colleagues feel very, very fortunate to have been able to do this work. I would say we have heard and seen quite a bit from payers and providers, especially around the need to change the way that we pay for care so that what we are rewarding through the payment system is directly aligned with the types of outcomes that we want to see. And so when we think about issues of health equity, how are we incorporating equity considerations into the way that we benchmark, design, and pay for care? And today I'll be speaking more on the work that we've done on the measurement front, and in particular, some resources on healthcare measurement that we've done, that we've developed for the Raising the Bar project, and how we think about the collection of race, ethnicity, language, sexual orientation, and gender identity data, because you cannot improve what you don't measure. And if we don't have benchmarks to understand how the system is currently performing for people, we can't figure out where to target resources and efforts to make things function better. I'll also stress, and I'll talk about this more later, collecting the data is necessary, but it's not sufficient. Just collecting the data does not mean that you have fixed any of the issues. You have to collect that information, but then continue to engage with communities and with individuals to understand their particular needs. So I'll pause there and look forward to the conversation.
Thank you, Josh. I'm reminded of one of the first things I learned when I was just starting to work in healthcare policy. And a supervisor of mine said, the thing is that if you don't count, if you're not counted. And another way of saying that I've heard in the maternal health spaces, you have to measure what you treasure. And so it's not just about being able to identify where the gaps are. It's also so that you can then design specifically to address those gaps. It's also about accountability, right? And so I'm really looking forward to having more of this conversation about measurement and what's missing. So you've all answered the question of, what's the most important thing that your institutions have done. I'm wondering if, understanding that these efforts are all multi-pronged, is there a key takeaway in terms of what makes the impact, what makes whatever the effort is the most impactful? And I throw that out to anybody who wants to answer that.
So, I would sort of, speaking a little bit more towards the effort that I'm discussing, I think in terms of making it more impactful, it has to actually be tied. So when we're talking about leadership, it has to be tied to sort of high stakes. So in our case, it was actually tied to metrics and to thresholds for performance that actually impacted both health system leaders' compensation as well as providers. So, that's sort of another way at getting at things and sort of pushing it so that everyone is motivated in another way to achieve the gains. You then have to, of course, filter it through and make sure that you are incorporating the multi-prongs that we sort of talk about and definitely listen, et cetera. But I think that is one that was different for us, and I think definitely was key to the emphasis that we subsequently paid in this area.
Yeah, I think that's really interesting about your model, because it's something that we hear about all the time in like the corporate world, right? Mm-hmm. People get paid according to their performance, and they get measured in that way. And the fact that compensation for those who make the decisions of how resources are distributed and implemented was tied to actually a positive result for a community that is really feeling the pain and hurt of the crisis was innovative in the healthcare space, not so much in the rest of the world. But one of the things that we heard loud and clear in all of the work that we were doing in raising the bar was the importance of leadership and the importance of aligning the metrics and payment and resources to be able to solve the problem. Patty, was there anything you want to share about what makes your initiative as impactful as it is?
Yeah, I just would say that, anytime you have an intentional partnership with the community, it has to go both ways. There's a long history of people going to the community and saying, we need this from you and tell us your opinion and what you want, but we have to, it has to benefit the community. We have to bring things back to the community. And I think that's starting to be recognized more, but it's part of building the trust with the people that you want to partner with. Integrating their voice and making sure that you acknowledge and integrate that into whatever it is that whatever steps you take.
And that is
the other thing I would say is that it has to be entrenched in the organization, because if the partnership just depends on me and another person being in our roles, and if we leave, then the partnership falls apart. It has to be really, there has to be, like you said, leadership buy-in, and it has to be permanently ingrained in the way we work.
That's a really, I think, critical point, because first of all, like we've heard that a lot, that we need, and when we saw this in spades when it came to the COVID pandemic, right? That there was, a lot of us have been saying there's a real problem with trust and medical institutions. And it's not because these people are, paranoid. It's because institutions have been functioning in untrustworthy ways for generations, right? And so how do you build that up again? And I think what you're saying is that it has to be a combination of really meeting the community where they're at. And sometimes that's actually literal, like don't make them go to your ivory tower, go to where they are. and building human relationships, but that is not enough, right? Because trust is among people, right? And so that's really important. But you also need to build the infrastructure and the resources so that the trust can really can be leveraged into true collaboration, and not just we're taking information from you and we're going to do what we want with it. Hopefully it'll work out for the best for everybody. We're beyond that. And it is one of the things that I think a lot of we often get questions about, like, well, then where do you start? How do you start building trust in a community that actually has really good reasons not to trust your institution? And so I'm wondering if any of you want to say anything about what would be like an example of a first step. I mean, we do have an entire section on partnership, on effective partnerships in our Raising the Bar toolkit. But I think it would be great to hear from you.
I'll offer a comment. Some of this is from my experience working on Raising the Bar Part 1 and some of the interviews that we've done with folks from the sort of community engagement perspective. We heard pretty loud and clear from both patient advocacy and community advocate groups, as well as from some of the more forward-thinking provider organizations, about the importance of coming to communities not focused on a sort of deficit mindset or I'm going to come in because I have the data and the resources and tell you how to fix your issues, but instead coming in with the interest of listening and hearing from them, partnering with the community, and first identifying what are the needs of the community as identified by the people within the community, and how can you help to sort of amplify and strengthen their voice and raise up the issues that community members are identifying. Not necessarily because it's a goal of your organization clinically, like reducing hemoglobin A1C rates or rates of hypertension, but because the community members have identified that, we have issues with community safety, or the streets aren't walkable and the sidewalks don't connect to the bus stops, right? Some of these are very tangible things that occur outside of the clinic. And I think it's very easy from a healthcare perspective to be focused on activities within the clinic walls first and foremost. And oftentimes that focus means that you are not necessarily being responsive to what communities need. And part of this building trust and relationship with the community might mean taking a step back and focusing on what that community needs first.
And that's a really important role, right? Because if you know that there's a pretty simple problem in the community, that may require some advocacy, right? Like in many places, healthcare institutions are very, very powerful as economic drivers in their communities and have a lot of connections. And so like, it means a lot when you have the hospital speaking to, the Board of Aldermen or whatever that municipal structure is to say, hey, you need to fix this problem with the sidewalk. You're probably going to have a little bit more success than if the community by itself was trying to get the attention of folks, when these are communities that have been politically and structurally marginalized for a long, long time. I want to recognize for a moment a great comment that's in the chat right now. First of all, to remind folks that we will have time for question and answers from the audience. So please put your questions in the chat. And I will be asking them later. But also to recognize that community health workers, I think, are the best, an incredible example of how health systems can build on the assets that communities already have. And community health workers, I like to call, they're like, the Swiss Army knife of peer support, where a community health worker that is grounded in the community. And I must disclose, my mom at one point was a promotora de salud, which is what they're called in Spanish-speaking communities. So I'm a little bit biased in favor of that. But to have community health workers that already have the trust of the community and are an asset in their community, and building on that can be incredibly powerful, not just because of what the community worker herself does. And community health workers, in my, when we talk about them, we think of a really broad umbrella that includes community-based doulas and community-based peer support worker, that kind of thing. And it's that when you actually invest in the entity, in the community health worker, and the entity in the community that actually employs them, whether it's a nonprofit, community-based organization, you are actually going to get a multiplier effect, right? Because it's not just what she does, it's the fact that you're helping to fund an FTE in the community. It's that you're helping develop the leadership in a community. And that is invaluable. That's harder to calculate, but it makes a huge difference. What we don't want, and this has been really clear, is for hospital A to decide, oh, community health worker, that sounds like a great idea. Let me put out a job description and hire like 17 community health workers with bachelor's degrees in public health that may or may not be connected to the community, or just hiring out from the community health workers that are there and sitting them in a room, in an office, in a hospital. Like those are not effective ways to invest in community and community health workers. So that's just kind of one illustrative example. Josh, I was hoping that you could take a bit of a deeper dive on the whole measurement issue, because at the end of the day, measurement is one thing that is connected to not just a quality improvement. Measurement is connected to, in some cases, payment. And it's a way, as long as the measurement is done well and in a transparent way, it's also a way that communities and others can hold healthcare institutions accountable to improvements that are much needed.
Sure, of course. So yeah, one of the things that we worked on at the task force side as part of our involvement in round 2 is the development of specific operational guides. One of those was focused on measurement, in particular looking at race, ethnicity, language, sexual orientation, and gender identity. Before I dive too much into the operational guidance, I want to put on my, public health, anthropology, biology hat and just stress the fact that we often slip into talking about these identities as if they are biological constants or absolutes. And these are really social constructs. And so I think it's important to sort of stress that what we identify around race and ethnicity in America is not necessarily what everyone else is going to recognize or identify as. And so, as I mentioned earlier, collecting this information is not a replacement for community engagement or building relationships with individuals, understanding their clinical and personal histories. But gathering this information is really important to give us the sort of underlying background on what is going on. And it allows organizations to begin to track and identify areas where they might be, falling short. All of this is an interaction between our genetics, our genotype, our phenotype, epigenetic factors, how the environment sort of impacts us, and then how our broader society views us, and then how we view ourselves. And so I'd just like to sort of frame that up before I ever talk about measurement in any of these areas. So a few things that we've identified as being issues or gaps in this space. There's a lot of discussion at the healthcare organizational level about who is collecting the data. Right? We think about payers versus providers in the data collection space. There are efforts that payers make to gather information on their members, that providers make to gather information on people. And I think there's concern about redundancy and effort. Too many people are asking patients and individuals the same questions over and over again. Also issues around how the data is being collected. So if you are collecting it at the clinical level, have you put the time and the energy into training your staff on how to collect this information? We talked to some diversity, equity, and inclusion leaders at one healthcare organization, someone who was mixed race and who said, I came in with my kids one day and my hair was straightened and down and I was coded as being white. and I came in the next day and I had my hair in braids, and I and my other child were coded as being Black. And it was because there wasn't a direct interaction with her to ask her how she identified. Instead, it was a very busy admin person who was checking them in who needed to sort of fill in the form, right? So that's a sort of concrete example of some of the challenges. We also heard from providers, provider organizations, that there's a lot of reluctance and concern about what broaching questions about your race, ethnicity, your sexual identity, your gender, or your gender identity and sexual orientation, what that might mean for the interaction between a patient and a provider. Is that going to put a patient on edge and make them wonder, why are you asking this information? And how is this clinically relevant for my care? Or if your payer is asking this, how is this data being collected? And where will it go? Could it be used potentially to discriminate against me? Or could it get out in some other context? So there are concerns about safety and confidentiality that have come up. And then finally, how is this data being interpreted and being used? So race, ethnicity, sexual orientation, gender identity data, this can be potentially, clinically relevant. Sometimes the way that we visually present our phenotype and our genotype map together for, clinically relevant reasons, like concerns about prevalence of sickle cell anemia or cystic fibrosis. Other times, racial information is misused, and we've heard more recently in other areas the task force has worked on concerns about this being used in algorithms and in AI. We know that there is a history of, in pulmonology and hematology in particular, differing standards for clinical measurement that varies by race, that has more to do with how the data was collected initially than what is actually best for the patient. So, there's lower acceptable lung function levels for Black patients on some of the sort of standardized scales than there are for white patients. And, that's an issue that we've had people raise in many forums now and express some concern with. So in the guide that we put together for this, we really tried to step through developing a current assessment of the state of data collection within your organization. That includes understanding who's responsible for collecting the data, what data you are collecting, and engaging with the community to ensure that you have identified other sources for data that could potentially be used. We then move into developing an improvement plan. So having very clear goals for what type of data you need to collect, because what we collect in the census for race and ethnicity may or may not be relevant depending on the community you're serving. In Minneapolis, identifying as Black might be African-American. You also might be a recent immigrant. And those are two very different cultural contexts and mean something different in the way that that person might be experiencing race, racism, discrimination within a community. And then we move into finally developing and implementing a plan to refine data collection, and then how you're using and sharing that information. Because ultimately, as you mentioned, Sinsi, I think there has to be transparency in how this information is being used, and organizations have to be willing to report out to the community about how they are performing, because that is part of this accountability loop that we've talked about, having accountability at the level of leadership, but also down through the organization for identifying issues with equity and proactively addressing them.
Thank you so much for that, Joshua. That gave us a lot to chew on. The first thing I want to say is that, all of these guides are available, or should be available, if not now, in the very near future, on our Raising the Bar site at the National Partnership. We can share that information. And I also thank you, Joshua, for reminding us very clearly that the issue that we're dealing with is not race and ethnicity, it's racism. And racism, it's both in how individuals treat each other, how you may be treated in a hospital, or in a clinic, but it's also structural inequities, right? That have been built into everything from how algorithms work and how measurements were created. And, you know, we could go on and that, and I'm sure some of you might be interested in that, but I think it's really important that we also acknowledge the point that Josh was making about how the categories that you look at may vary depending on where you are. So for example, I mentioned before, when you look at Latinos across the board and you're mixing together people from very different backgrounds with very different experiences with either colonialism or immigration or racism, you know, that it's really important, for example, let's say in the Northeast, that you are looking at Puerto Rican outcomes separately from the rest of Latinos. And each institution needs to understand what their context is for it to be relevant. But it's very, very important that we don't overgeneralize in different groups, because it will erase disparities. And that is especially true in the case of Asian Pacific Islanders too. So the last point I wanted to make based on what Josh was saying is that he talked about the importance of assessing where you are. And one of the things that you will see across the Raising the Bar, the 4 roles, is that we do have guides on what you should be assessing to start off with. And also I want to stress that making sure your assessment happens and that it's finished should not stop you from making common sense changes that you know will be beneficial, right? Sometimes we often in the equity spaces hear, oh, we need more data, we need more data, we need to know more about what's going on. It's like, well, more data is always needed, but it shouldn't stop us from taking action and moving forward. So I think we're about ready to start with questions. And please remember, put the questions in the chat, because that's my favorite part of any presentation, is when we actually engage with the audience. So the first question we have is, can you discuss the impact of the intersection between racism and ableism on maternal and child health? And Abike, sorry, I mispronounced your name. Do you want to start us off?
Yeah, I mean, one of our sort of activities, actually, we've done, so we've had to address things, holistically. Part of this has been doing trainings when you do some implicit bias trainings, there is some awareness of our biases, and really the intersection of the two are there. I mean, there's sort of intersectionalism throughout the spaces. I mean, it's not only just sort of racism, ableism. Josh spoke about LGBTQ issues, and I think it's inherent that we educate ourselves on these issues sort of in totality, and make sure that that is sort of intrinsic within the efforts that we're doing.
Anybody else want to? Sorry, having a problem with my mute. Anybody else want to respond to that question?
I'll just add that, partnering with the community and listening is so important. I know, and integrating their voice. We had our big hospital in St. Paul was undergoing a huge remodel, redo of their whole birth center. And so they talked to the community and really had some hard conversations, heard about historically how they've been viewed and things that have happened. And they took that on board. And I think that was pretty hard to hear, but they took it on board, and the community input really impacted everything from the layout of the facility to their visiting hours and their visitor policies. And now I've been told by birth workers that Regions is one of the hospitals, is the hospital of choice in St. Paul for Black women, especially because they do feel safe and they feel heard and they feel comfortable there. So.
Thank you so much. Moving on to question number 2. I love this question, been working on it for a while. How do you work with payers, especially public programs like Medicaid, when it comes to doula reimbursement? Patty, do you want to start and with an answer to that question?
I wonder if you teed that up for me. We are a payer, and I work primarily with Medicaid reimbursement. And like I said, in Minnesota, Medicaid has reimbursed for doula services since 2014. So quite a few years, but there's still barriers. And one of the biggest barriers is the reimbursement. The Medicaid reimbursement is like a third of what a private pay doula would make. So it's really hard for a doula to justify working with a Medicaid member, leaving their family, missing out on kids' birthday parties because they're going to support another mother in their birth. And so one of the things that we did, kind of down the line, but was really important is increase our reimbursement for the doula services. So we looked at like the usage and how women are actually using doulas. And it was a very small percentage, less than 1% when we kind of started on this journey. And not everybody uses in Minnesota, you can have 6 visits with a doula pre and postnatally, and then the birth visit is a separate visit. And so not a lot of women were using all 6. So when we increased the rate, we weighted it heavily on the birth visit because that is really the bulk of what the doulas kind of rely on for their income. And I think that was a really important recognition of the cost and the value of the doula. The other thing that we did, and health plans, a lot of health plans have foundations and things like that. We don't have one of those, but we do offer grants for specific projects a lot of the time. So we offered Everyday Miracles as our main doula partner. And so we offered them a grant to pay for doulas of color to get certified. So because it's really expensive and you don't actually get paid for being a doula for a long time once you start. There's cost to register with the state so you can bill Medicaid. There's just a lot of upfront costs. So we included the cost of registering with the state in that reimbursement so that people were able to kind of get kicked off with their career quicker. And I think that has really made a difference in raising the reimbursement rate has really made a difference in retention of doulas. And so like Everyday Miracles with the grant that we gave them and from another organization, they went from having 40% of their doulas be people of color to 70%, which is a huge increase. And for our members, we went from having less than 1% to almost 5% of our births in 2022 be accompanied by a doula. So that's a huge increase. It's still not a lot, but having doulas of color available to those members, I think, has been a real benefit. And the other thing that I will say is, not just our payment policies, but partnering with the community on other policies is important. We have legislation in conference committee right now to increase the Medicaid reimbursement rate to a really equitable pay, and also to make it simpler for Medicaid or for doulas to bill Medicaid by kind of cutting out the clinician supervision requirement. And our organization signed on publicly to support that. So I feel like that's a really important step to support the birth workers that we work with.
Patty, thank you so much for that answer. And for highlighting one thing that's really important, especially for those of us who have been working in like the payment and delivery reform system transformation space. Too often when we look at alternative payment models, we're just talking about paying for the care you know, whether it's an episode or, you know, per member per month, and that by itself is not enough to turn the tables when it comes to equity, because it doesn't address the underlying generations of underinvestment and, you know, extraction of resources from communities of color. And so you need to be able to do both, right? Like help with those gaps, kind of on the front end, like helping to pay for the training, and for getting certified, or, you know, being able to be a Medicaid provider, but then also, you know, the ongoing care that's provided. And that first part about how do we like level up these communities and that haven't had resources is often like completely ignored in some of these conversations. So I really appreciate you bringing that up. I do have a couple of more, we're quickly running out of time. I do have a couple of more questions. And I see a lot of requests for having a part 2 of this discussion, and I'm sure we will all take that to heart and figure out how we can make that happen. But in the meantime, this is, I think, a really important question for Dr. James. How did you get hospital leadership to tie maternal equity performance to their comp? I mean, that just seems like, that's like next level.
I cannot take full credit for it. I think it was a confluence. You know, I think after 2020, our twin pandemics, and George Floyd, you know, there was an awakening, and I think a lot of us who were in the DI space seized this opportunity. So there was a lot of education that extended across the leadership spectrum. We had already been doing some of the work, but we needed the leadership buy-in. But I think it was the combination of things that really elevated this. Our chair, we had a new chair at that point who also came in, whose work, Dr. Elizabeth Howell, who actually was part of the Raising the Bar project, who obviously also saw this as a priority. So I think sort of together, it was sort of ripe to have this as one of their really only 2 or 3 team goals per year. And again, across the institution, across all entities. So I think it was sort of the combination of all of these things that it was elevated enough. And there was this faith that we could do the work. And so it became that. Apologies for.
Yeah, I think that is like, you know, being able to be prepared for when an opportunity and when the appetite for something is there, to jump on it, right? To really take advantage, leverage that opportunity. So we're running out of time, and I want to close us off with a chance for very quick answers from each of the panelists. And I'll let you pick. If you were either tell us about the one thing you wish you had known when you were starting the work that would have made your life easier or your work more successful, or which can also be, what is the one piece of advice you'd give to our participants today on how to get started? So why don't we start with Patty?
There's a lot of things I wish I had known. One thing would be that not every community organization is the same. And so you really have to kind of recognize what their needs are and what our needs are, and tailor our approach to the individuals. No one size approach is going to fit every situation. And I think the other thing I would say is that it's so important to ask the community to find out what from them, what the barriers are and what the solutions are, and you know what's already happening that we can build on. One of my favorite kind of phrases from community work is "nothing about me without me," and that has been especially true with our work with the doula community. So we trust the community to be great partners.
Excellent. Dr. Abike, do you want to go next?
Sure. So it's so interesting because the one thing I would also actually echo Patty that and they've spoken to it was inclusion of the community from the start. So I've talked about sort of our program, and a lot of this was generated from within the walls of Penn. We have because it's been multi-pronged, we have recognized this, and we are definitely making more steps at this point. But you know, I think the other thing that I would want to just make sure comes across is that no matter sort of what area you're in, that there is there's a role for you to play in achieving maternal health equity. You know, I think beyond this, as a leader, you can make these bold goals in hiring. You can ensure the workforce is representative of the population being served. You know, as we've done more listening, the trust issue is so major. I think one of the things I wish we really sort of paid attention to that and been intentional, because we've done a lot of sort of gains in the clinical spectrum, but there's still more to be done to address that mistrust and to eradicate it.
Thank you. Josh, do you want to close this off?
Sure thing. So I will flag, I think, two things. One, I saw some folks in the chat talking about the data sharing piece. And I think there is a sort of knee-jerk reaction oftentimes to just say no, rather than to dig into what sort of information can and can't be shared legally. You know, it is people are worried about getting in trouble, but clearly being able to map out what information is needed by whom and when, and whether that information needs to be identifiable or not. There's a lot more barriers around sharing identifiable sort of patient level data that's used for clinical care than there is around sharing things like de-identified reports on performance within a community. So I think we need to think very hard about when do you need clinical level identifiable data, and when can you really get started with just community level data that might already be collected in the census. And then on the leadership point that Dr. James has raised, I think we heard from a lot of organizations that there needs to be strong sort of central leadership. You need to have someone who's in charge of diversity, equity, and inclusion. They need to have real power in office and some staffing. At the same time, it is everyone's responsibility to do this work, but we had organizations that were very clear with us. If there is no one who is ultimately sort of responsible and accountable for making it go, if it becomes everyone's job, then it's no one's job. So you need to have that combination of dispersed responsibility throughout an organization with an accountable sort of entity at the head to make sure that they're driving that forward. And that person should be, you know, reporting directly to your sort of C-suite level leadership.
Thank you so much for that. And I want to thank all of the speakers for today's discussion. And especially thank you to the Robert Wood Johnson Foundation for supporting this project and today's conversation. I hope you all take some time looking at the Raising the Bar resources. They highlight that some of these organizations already working to raise the bar. We have insights to guide action. We have suggestions tailored that you can tailor for your own institution and the community's priorities. And we call out all healthcare stakeholders, providers, practitioners, payers, and others to join us in raising the bar for maternal health equity and excellence. Please visit rtbhealthcare.org to learn more. And again, thank you so much for joining us today. And, you know, pick the thing and do it. You just need to get started. And we'd love to hear more from you about what you are doing and your successes. Thank you so much and have a great afternoon.